All right, for those of you who are just joining us, we are just waiting for people to get logged in. We were able to open this session just a little bit earlier so we could get people set up in time to hear the full presentation. So again, for those of you who are joining us, we've just started the session a little bit earlier so people could get logged in. We'll begin right at 1:30, so in just a couple minutes. Okay, we're going to go ahead and get started now. Good afternoon. We're glad to have everyone joining with us for this session with Dr. Tarakad, long-term management strategies with Levodopa, where Dr. Tarakad is going to review the mechanism by which Levodopa has its effects, both short-term and long-term side effects of the medication, as well as treatment strategies and how to address those side effects. Many of you are familiar with Dr. Tarakad. He has presented for us on numerous occasions. He is an assistant professor of neurology and director of the DBS program at the Parkinsons Disease Center and Movement Disorder Clinic at Baylor College of Medicine. Dr. Tarakad received his undergraduate degree from Rice University and his medical degree from University of Texas Health Science Center at Houston. He then completed his residency training in neurology at Baylor College of Medicine in 2015 and completed his movement disorder fellowship at the Parkinson's Disease Center and Movement Disorder Clinic at Baylor in 2017. His areas of interest include deep brain stimulation, experimental therapeutics, and digital biomarkers in Parkinson's disease. He's published many scientific articles and is also a member of the HAPS Medical Advisory Board. So we welcome Dr. Tarakad today. Thank you.
Thank you, Kathleen. So today I'm going to be talking about long-term management strategies with Levodopa. And before we go into the strategies, I think it's important to understand what exactly Levodopa is. So Levodopa, or L-Dopa, is the immediate precursor to dopamine. It's a naturally occurring chemical in the body, and it's absorbed through the gut by something called the large neutral amino acid transporters. And then the last thing I have on this slide is that it crosses the blood-brain barrier, and that's important factor here. So with respect to the rest of the body, the brain is a relatively protected structure, and for good reason. Aside from our skulls that prevent physical trauma to the brain, the blood-brain barrier acts like a filtration system that prevents infectious agents or certain chemicals from traveling into the brain via the bloodstream. This filtration system also happens to do a good job at blocking dopamine, which is why we have to use Levodopa instead of just giving patients dopamine as a treatment. Also worth mentioning that large neutral amino acid transporter that I talked about as helping with get Levodopa from the gut into the bloodstream is also involved with getting Levodopa from the blood into the brain, so across that blood-brain barrier. So now that we understand why we use Levodopa as a medication for Parkinson's rather than plain dopamine, let's discuss some of the limitations of Levodopa therapy. So the first one that I have here is drug delivery. So Levodopa, at least right now, is largely limited to oral formulations. And this is because it's a relatively insoluble chemical at neutral pHs. So it's soluble in acidic solutions, which can be a challenge when delivering it through the skin. So anytime you need to use like a gel or a liquid or something like that, it needs to be acidic, and that doesn't work that well as a medication. Next, we have the absorption. So levodopa is absorbed in the proximal gut, again, through those large neutral amino acid transporters that I talked about. And this is only in the duodenum and the early part of the jejunum, which are the first segments of the small intestine. This means that if medication is backed up before this, like if you have gastroparesis or delayed gastric emptying, which you can certainly see in Parkinson's, then the medication isn't going to get absorbed. Similarly, if the medication passes this point, as you might see when medication is competing with protein for absorption, whatever passes that point of the gut isn't going to get absorbed. Next, in terms of limitations, is the short half-life. So the half-life is the time that the concentration of medication drops by 50% of its peak level in the blood. And for levodopa, that half-life is about 50 minutes. This is relatively short compared to other medications. So a lot of medications have the half-life on the order of a couple hours, or in some cases a couple days. So relatively speaking, it doesn't stay in the system all that long. Next, with limitations is short-term side effects, and there are a lot of side effects that we know about that are possible with levodopa. The most common ones that we run into are nausea, sleepiness, and dizziness. Those latter two are more often caused by low blood pressure that you can see associated with the medication. Beyond short-term side effects, there are also long-term side effects with levodopa, and this is where we're going to be going into a bit more detail later in the talk, and this is something called motor fluctuations, as well as dyskinesias. So we have a number of different strategies to try to overcome these limitations with levodopa, and one big one is this medication called Carbidopa. So Carbidopa has been paired with levodopa in the US, pretty much all formulations of levodopa in the US since the 1970s. And it has two effects. So it extends the half-life of levodopa from about 50 minutes to about 90 minutes. And this is by blocking the conversion of levodopa into dopamine. And another important factor of it is that it doesn't cross the blood-brain barrier. So these two actions or these two effects of Carbidopa are pretty important. First, blocking levodopa's conversion to dopamine peripherally helps minimize the effects that people or side effects that people can get from levodopa. So things like nausea tend to be better when you take Carbidopa. And second, because Carbidopa doesn't cross that blood-brain barrier, it effectively concentrates the levodopa in the brain rather than letting it stick around in the blood. It's worth pointing out that the half-life of levodopa, whether we're talking 50 minutes or 90 minutes, is the serum half-life or the blood half-life. And we don't really have an easy way to measure the half-life of levodopa in the brain. So it likely sticks around in the brain a little bit longer than what we get when we record it in the blood. Outside of the addition of Carbidopa, a number of different companies have developed different formulations of levodopa that can have varied effects. So immediate release levodopa, just regular levodopa, sometimes we call it Sinemet IR. These are the yellow or blue pills that a lot of people are going to be familiar with. So that is just sort of your baseline standard levodopa. Parcopa is pretty much like Sinemet IR in terms of action. It just dissolves in the mouth, which can result in a faster effect, also makes it easier to swallow if you have trouble swallowing, but it's still getting absorbed in the proximal gut. So in terms of where it gets absorbed, how it has its effects, going to be very similar to just immediate release levodopa. Sinemet CR, which is a controlled release, is a slower acting version of levodopa. It's not as readily absorbed as Sinemet IR, and this means that about 75% of the medication gets absorbed compared to 100%. It's also more susceptible to food interaction, but this delayed absorption allows it to have a longer duration of effect. Rytary is another type of slow release or extended release carbidopa levodopa. It's a newer version. It's a mix of slow and fast release beads inside the capsule. So this slower effect translates to fewer, at least short-term side effects with the medication. So a lot of times if people are having trouble tolerating it, you can try using Rytary in place of regular carbidopa levodopa. Inbrija is an inhaled levodopa. This isn't used as what we call maintenance therapy, but more as like a rescue therapy. It's relatively fast acting, so works within 5 to 10 minutes. It bypasses the gut, it gets absorbed directly through the lungs. So it's this rescue medication because of that fast effect. And then last here we have Duopa, which is a continuous levodopa infusion through a pump that connects directly into the small intestine through a stomach tube. So this is used more for advanced treatment, and we'll talk a little bit about it later. So beyond altered formulations of levodopa, there are a number of different strategies that we can use to help overcome the side effects. Because levodopa will compete with protein for absorption through that large neutral amino acid transporter, if you pair the medication with food, this can actually help slow the absorption into the system. And if you get this slowed absorption, that can help mitigate some of the side effects that you can see, like the nausea, drowsiness, or dizziness with the medication. The slowed absorption might also result in less total medication getting into your system. And on the one hand, less medication means less side effects, but this might also decrease the effectiveness of the medication. So something you need to be careful with. Other strategies include adjusting medications that might help counteract levodopa side effects. For example, dizziness from levodopa is often caused by low blood pressure, and one simple solution can be reducing or stopping blood pressure medications, especially if they're no longer needed. Dizziness is also a common side effect from a lot of other medications, and if these other medications are being used, so things like dopamine agonists or certain bladder medications, that we often run into with Parkinson's, then sometimes if you switch to alternatives or reduce these medications, then that can help reduce side effects with the drops in blood pressure. Drowsiness is another common side effect that we can see with levodopa, and this might require a reduction or change in other medications. First and foremost, sleep medications can contribute to this, so it might be just backing off of those or other medications like anxiety medications. Aside from changing other medications, we may need to actually add other medications to treat levodopa side effects. Because levodopa is such an effective treatment for Parkinson's, this is one of those few situations where physicians might seek out polypharmacy. Usually we're trying to cut down on the number of pills we use, but in this case, we might be adding onto it just because levodopa is sort of our best treatment option or most effective treatment option. So some examples here can be adding a medication for nausea like Zofran or Tigan, using a stimulant medication for drowsiness, so things like Nuvigil, or using medications to raise blood pressure like fludrocortisone, midodrine, or droxidopa. So this is when we talk about these side effects with levodopa, that's really only half the story. So Parkinson's disease continues to change over time, regardless of whether or not you're taking levodopa. And you might have heard in an earlier talk, but we always like to quote this figure that about 70% of dopamine cells in the substantia nigra are lost by the time people first start having symptoms of Parkinson's disease. And while this cell loss tapers off, it doesn't stop completely. So additionally, longer term changes can occur in the cells that you have left over in the dopaminergic system. So these cells can become sensitized to dopamine, or in other words, just hyper responsive to dopamine. And because natural dopamine is released in a continuous fashion, and when you give the medication, it's released in more of this pulsatile fashion, it's thought that these pulses of levodopa or dopamine might further contribute to some of those long-term changes that we see within the remaining cells. It's also worth noting that while Parkinson's disease is normally thought of as a disease affecting dopamine cells in the brain, other parts of the brain can become affected over time. So this can involve things beyond the dopaminergic system. So this takes us to those long-term side effects that I talked about earlier, the first one being motor fluctuations. So when we're talking about motor fluctuations, it's really that distinction between what we call on time, when the medication is working, when you can move and when you can function better, and then off time when you might notice more Parkinson's symptoms resurfacing. It's also important to note that you can have non-motor symptoms that fluctuate as well. So things like anxiety, sweating, fatigue, or even thinking clearly, you might see on versus off time with levodopa. While you may hear a doctor talk about on and off time, in mild Parkinson's, these distinctions aren't always readily apparent. You might not fully appreciate it, though when people have Parkinson's for a longer period of time, they might start noticing these more pronounced fluctuations. In addition to the more noticeable changes that you can get with symptoms in longer standing Parkinson's, the on time can start to decrease, so that duration of on time can decrease and the duration of off time can increase. You might also see that medication is a little bit less reliable, where you can run into this thing called no on phenomenon, where you take the medication but it feels like it doesn't work. Sometimes we call that failed dose effects. And then also just a delayed effect for the medication to start working after you take it. So what causes motor fluctuations? So this goes back to the changes that occur in cells in longer standing Parkinson's disease, specifically that sensitization of cells to dopamine due to chronically low levels, as well as decreased capacity of the cells to store dopamine. This makes them more reliant on the exogenously supplied levodopa. So there are a number of different things that can affect the risk of developing motor fluctuations. So first and foremost of these, which is why we'll talk a little bit about when to start levodopa in a few slides here, is this higher doses of levodopa. So we know that when you're on higher doses of levodopa, that puts you at a higher risk of developing motor fluctuations. Similarly, if you've been on levodopa for a long period of time, that also increases the risk. Though just a longer disease duration with Parkinson's is also a risk factor. We also tend to see motor fluctuations a little bit more in young onset Parkinson's disease, particularly in certain genetic forms of Parkinson's, we can see this. And then lastly, the presence of dyskinesias can also be a marker for an increased risk of developing motor fluctuations. So that brings us to dyskinesias. What are dyskinesias? So dyskinesias are these involuntary erratic movements involving pretty much any part of your body. They can involve the face, arms, legs, or trunk. More commonly, they're sort of writhing or jerking type movements, though occasionally they can be dystonic, which you can think of as like sustained muscle contractions or muscle spasms. More often, they'll affect the side that's more affected with the Parkinson's. Or at least first be noticeable on that more affected side. And they usually occur at sort of a peak time of the levodopa or during your on time. So it's more common 1 to 2 hours after you've taken a dose of levodopa. Also tends to be more common later in the day as the levodopa builds up in the system. Uncommonly, dyskinesias can also occur with wearing off or in something called a diphasic pattern, DID, which stands for dyskinesia improvement dyskinesia. This pattern of dyskinesias are often more dystonic rather than the writhing or jerking movements that we talked about, and then more often can involve the legs. So what causes dyskinesias? You're going to see a lot of similarities to what causes motor fluctuations. So there's that loss of dopamine storage capacity, that sensitization to cells with the to high levels of dopamine because they're chronically in that low dopamine state. But then also there's several pathways outside of the dopaminergic system that are thought to play a role in dyskinesias. To name a few, the glutamate system, serotonin, and GABA. So who's at risk for dyskinesias? So again, you're going to see some common themes with the motor fluctuation slide. So higher doses of levodopa, longer disease duration, and longer duration of levodopa therapy all put people at risk of developing dyskinesias. Young onset Parkinson's, again, is a risk factor. And just like dyskinesias were a risk for developing motor fluctuations, we can see that the presence of motor fluctuations is sort of a marker or risk factor for developing dyskinesias. Two additional risk factors that we see here are low body weight and then female gender as a higher risk of developing dyskinesias. So next, we're going to talk a little bit about how to manage motor fluctuations and dyskinesias. Because of the association of long-term use of dopaminergic therapy with motor fluctuations and dyskinesias, deciding when to start levodopa has been a little bit controversial. I think an important thing here is that while dyskinesias require the use of dopaminergic therapy, meaning that levodopa or dopamine agonists, or in some cases, deep brain stimulation, Parkinson's disease itself and its progression is what primes someone to develop Parkinson or to develop dyskinesia. So what this means is that chronic use of levodopa in someone with a healthy brain, they aren't going to develop dyskinesias. Furthermore, dyskinesias are more likely to develop in long-standing Parkinson's disease than early Parkinson's disease, and this is regardless of levodopa therapy duration. So when you've had Parkinson's disease longer, your brain is in some ways more primed to develop dyskinesias than it is early in the disease. And what that all boils down to is that levodopa is still the best medication for Parkinson's disease with the fewest side effects for most people. So here is a graph trying to demonstrate how levodopa levels impact motor fluctuations and dyskinesias over time. I'm sure you've probably seen some iteration of this before. I think there was even one in the last talk, but I think it's worth spending a minute here to really understand what we're looking at, just to better understand what we're going to talk about over the next few slides. So on the y-axis here, you can see the level of levodopa or dopamine, and if you trace this line sort of up and down, you can see this is the rise and fall of levels of levodopa over time. So if you take a dose, it's going to peak at a certain point and then drop back down, and then when it falls below a certain threshold, you take another dose. These valleys or troughs sort of correspond to taking a dose of medication, which will then cause it to go back up again. On the x-axis here, we can see time, and this is time sort of on two different levels. So if you look at this sort of up and down sinusoidal pattern, that's like you can imagine one day. So if you're taking levodopa, that dose goes up, drops down, goes up, drops down throughout the day. On the second level, we can think of this time scale more over the course of years, so how Parkinson's progresses over time. And this is where you can pay attention to these three sort of states. So off state is what we talked about earlier when you feel like the medication isn't working. On state is when you're functioning better, and then dyskinesias are when you're functioning better, but you develop these involuntary movements. And what you can see is that over time with Parkinson's, that threshold to get out of that off state starts to go up. And that's just because as you lose more of those dopamine producing cells over time, it takes more levodopa or supplemented levodopa to have that same effect. On the flip side with the dyskinesias, you can see that that threshold for developing dyskinesias goes down over time. And this goes back to that sensitization of the dopaminergic cells. So you're just more prone to having dyskinesias when you've had Parkinson's longer. So what you can see is as you've had Parkinson's longer, it's a lot easier to sort of fall into that off period as well as overshoot and go into that on period where you're having dyskinesias. So there are a number of different ways that we can try and adjust for the motor fluctuations and dyskinesias in Parkinson's. And one of the simplest, most straightforward ones is adjusting the medication dose and the timing of medications. And what this really translates to is taking lower doses of medications. And this is to try to help reduce that peak effect. So if you're not going up quite as high, you sort of avoid that dyskinesia territory. But then that also requires more frequent dosing. So you don't fall quite as low and again, avoid those off periods. So it's just trying to reduce some of the dramatic ups and downs that you can see with that pulsatile stimulation with levodopa. So an extreme version of this is with Duopa. So we talked about how that's a continuous infusion. It can be a 16 or 24-hour continuous delivery of carbidopa levodopa via pump. And this substantially reduces the peaks and valleys that you can see with levodopa therapy. So that's this little, sorry, I think I'm on the wrong screen here. So the little green line that you can see in the middle there is sort of an estimate of what you'd be doing with Duopa. It's important to note that while this has been shown to significantly reduce motor fluctuations, so off time, staying above that blue line, it's a little bit less effective in managing dyskinesias. So over time, and this goes back to those non-dopaminergic systems that are affected in Parkinson's disease, people still tend to develop dyskinesias even with Duopa therapy. So another treatment strategy that we can have for the management of motor fluctuations is adding medication to prolong the half-life of levodopa or dopamine. So MAO-B inhibitors, so this is selegiline, rasagiline, or sulfonamide, or COMT inhibitors, like entacapone and opicapone, can both categories can work to extend the effect of levodopa. So these medications effectively boost the effect and stretch out its peak effect. This can result in a significant reduction in off times seen in motor fluctuations, but may come at the expense of more dyskinesia. So you can see here, it just sort of like stretches out that peak effect of the medication, but that also means more time in this like above the red or in that dyskinesia territory. Because these medications are effectively like taking more levodopa, short-term side effects like nausea, drowsiness, and dizziness might also be more common with these medications. Another medication that you might hear about, which is, it's a different mechanism of action, but when you think about it in terms of these levodopa kinetics, it's the same effect, is Nurian. So this is basically having the same effect of reducing off time, possibly at that expense of more dyskinesias. Also similar to these strategies is adding another medication to supplement the levodopa. This is primarily achieved through the use of dopamine agonists. So dopamine agonists have a substantially longer half-life than levodopa, at least some of them, and they're available in a wider range of formulations. So there's a transdermal patch, there are extended release formulations, and much like the medications on the previous slide, they can help with motor fluctuations, but when used in combination with levodopa, they might result in more dyskinesias. And as far as the dopamine agonists that we use for this, Nupro, Requip, and Mirapex are the most common. So next up in these strategies is adding as needed medications. So these are more like rescue medications to help with unpredictable off times or delayed on times. And there are three currently available in this category. So the first one was Apokin, which is the subcutaneous injection of apomorphine, which is a fast-acting dopamine agonist. Inbrija, which is the inhaled levodopa that I talked about earlier. And Kinmobi, which is a sublingual version of that apomorphine. And what you can see here is it basically speeds up that on time. So when you start to notice feeling off, if you take it, it just tends to work a little bit quicker than the oral versions of levodopa would work. So it just helps reduce that off time. They have a relatively short duration of effect though, so usually they need to be used in conjunction with regular oral levodopa. So another strategy to more directly treat dyskinesias is to add a medication called Amentidine. So Amentidine is also available in a long-acting, slow-release formulation known as Gocovri or Osmolex. And Amentidine achieves its effects by essentially raising the threshold to develop dyskinesias, meaning that you can afford to take more levodopa or other medications to reduce off time without being as prone to developing dyskinesia. So this purple line here you can sort of see is like the threshold that as you sort of raise it when you take Amentidine. However, Amentidine is what I term a dirty drug, meaning that it acts on a lot of different receptors in the brain. These can include dopamine, acetylcholine, and glutamate. And we think it's this anti-glutamatergic effect which helps treat the dyskinesias. But being such a widely acting medication also means that it can be associated with a large number of side effects, which often limits its use. There are no other medications that are currently available to directly treat dyskinesias, though there are some that are being researched right now. Before I move on to the next category here, I think is worth just making a quick mention of this category of medications called VMAT2 inhibitors, just because there's a lot of advertisement for them. They treat this condition called tardive dyskinesia, which is completely different than levodopa-induced dyskinesia. So the mechanisms behind it are very different. When we look at how these medications work, they work by blocking dopamine release, which is not a good idea in Parkinson's, can tend to worsen Parkinson's disease symptoms. So that's why these are usually not going to be effective medications in treating Parkinson's types of levodopa-induced dyskinesias. So moving on, the last of these graphs is going to try to explain the effects of deep brain stimulation on levodopa kinetics. So deep brain stimulation has two primary indications in Parkinson's disease: to treat tremor that's refractory to medication, and then to treat motor fluctuations and dyskinesias. And DBS can achieve this effect through that second effect through raising the threshold for dyskinesia. So much like Amentidine, you can see that threshold is raised, which lets you basically use more medication without causing dyskinesias. It also can raise the baseline level of activity. So if you have this DBS that's going 24/7, then that can help cover some of the motor symptoms in between doses. You don't really need to take as much medication there. So since you're starting from a higher baseline, it's a little bit easier to avoid those off times. So you can see it's just this combination of reducing that dyskinesia threshold and more of that motor stimulation that can help reduce both motor fluctuations and dyskinesias. So the last thing that I wanted to briefly talk about here were future directions of dopaminergic therapies. So in the near future, there's a lot of interest in subcutaneous levodopa delivery. I'm sure that was probably discussed in one of the earlier presentations. But basically, much like that Duopa pump that I talked about, this is just a less invasive version of that. Several companies that are working on clinical trials that are fairly far along. The main limiting issue there goes back to that acidity of the levodopa causing skin irritation or skin nodules. There's also been a long-standing interest in cellular therapies, which can include altering genes that increase dopamine production in the surviving cells of the brain, as well as replacing lost dopaminergic cells. That second category is stem cell therapy. Historically, that's probably been of greatest interest to patients, and it's often already marketed as like a cure for Parkinson's disease. And while I think that we're somewhat far away from a cure, there is this recent article that I'd refer you to. It's in the Movement Disorders Journal, came out last month. It's geared a little bit more towards healthcare professionals, but I think it does do a good job in sort of explaining the expectations and the limitations with stem cell therapy, at least in its current form. So in summary, levodopa is a naturally occurring chemical in the human body that's required to make dopamine. Levodopa remains the most effective treatment for Parkinson's disease, and then factors that limit its use are methods of drug delivery, its short half-life, short and long-term side effects of the medication, including motor fluctuations and dyskinesias. Neurologists have many treatments in their toolkit to try to address these limitations. This can include alternate formulations of levodopa, levodopa modulating medications, or deep brain stimulation. And the general strategies behind management of motor fluctuations is going from that pulsatile dosing to a more continuous dosing for dopaminergic therapy, so flattening those peaks. And the management of peak dose dyskinesia can be aided by similar strategies, but often additional treatments like Amentidine or DDS must be employed. So I believe we finished with time for questions, if anyone had any.
Yes. Okay. Thank you so much. Give me just a second. I'm going to stop sharing your screen. All right. So we did have several questions that came in during the course of your presentation. You talked about the blood-brain barrier. Can you explain a little bit about what that is for people who might not be familiar with that term?
Okay, so the blood-brain barrier is basically this, you can think of it like a lining of cells that blocks or that shields the brain from the blood vessels. So if you have something that's circulating in your blood, it can't just readily diffuse into the brain. This is more important when we think about infections. Obviously, the body's going to protect the brain a little bit more than other organs. So everything sort of gets filtered through. So for something to get into the brain and guess the fluid that sort of surrounds the brain, it gets filtered through certain cells, certain channels, certain transporters, and that's where that neutral amino acid transporter can be involved in the transport of levodopa across that barrier, but doesn't allow dopamine across that barrier.
Okay, thank you. What about carbidopa levodopa extended release? Is it worth trying to improve in order to improve on time?
So there are a couple different formulations. When we talk about extended release, the CR and the Rytary, I think depending on the pharmacy or the prescription, the generic written version of both might be written as extended release carbidopa levodopa. It can be beneficial in some cases. Again, I think it's a case-by-case basis. As I mentioned, that delayed absorption can lead to problems with food interaction. So at least in our clinic, we don't tend to prescribe Cinemet CR very much during the day, mainly because it can interact a lot with food, and what you get in terms of effects from one meal might be very different for the next meal. On the flip side with Rytary, that seems to do a little bit better, at least in our experience from the food interaction standpoint. The main downside with it, which is also its upside, is it gets into your system slower. So that can help with side effects if you're sensitive to levodopa, but especially for people who have been on levodopa for a while, they might not feel like it kicks in quite the same way that immediate release levodopa works.
All right, thank you. Talked a lot about the motor side effects and negative motor side effects associated with long-term levodopa use, but what about the non-motor? Are there negative effects on the non-motor symptoms that people have that they should know about or be concerned about?
So non-motor fluctuations are, in general, I think non-motor symptoms in Parkinson's are not nearly as well described or researched. It stands to reason that because you can see these non-motor fluctuations pop up the same time you see motor fluctuations, that those same risks apply. Again, I don't think it's a long-term dangerous side effect. It's just noticing these changes between off and on can be more dramatic when you're on levodopa for longer periods of time. In terms of managing non-motor symptoms, it's probably a whole talk in itself. But obviously we have medications to treat mood symptoms, to treat cognitive symptoms, to treat fatigue. It's probably one of the tougher ones to treat, but we do have treatments for a lot of these non-motor symptoms, so certainly worth bringing up with your doctor. But yeah, there's definitely a likely link with non-motor symptoms or non-motor fluctuations, just probably not as much literature about it.
Okay, and then we had a question that says, you don't hear much about Parcopa anymore. Why is that?
I mean, it's essentially the same as if you just crush the pill yourself. That might be why. So you can get a similar effect to Parcopa just by crushing immediate release levodopa or dissolving it in something. So that would be my best guess. It's not that it doesn't work well. I think it works fine. I still have a handful of patients who prefer it, but I think it might come down to a cost issue too. But if it costs a little bit more and you can get the same thing just by crushing the pill yourself, there's that question of why take it.
All right. So are there benefits to starting levodopa early in the diagnosis versus waiting?
So I think the main benefits are it's going to be the most effective medication. So when you look at sort of things that you're not able to do after you're diagnosed, Parkinson's change is slow, but a lot of times I tell patients, look back 5-10 years, what were you doing then? Or the things that you've scaled back on. So if you're able to be more active, exercise more, obviously that's going to have more health benefits for you and probably worth the risk of that you incur when you take at least low doses of levodopa. Also, when you think of side effects, so the other main category that we think about when we're talking about early treatment is dopamine agonists. And when you compare levodopa to dopamine agonists, there's a lower rate of dizziness, drowsiness, impulse control disorders, a few of these other side effects, hallucinations. So there might be some value there. But again, it's very different on a case-by-case basis, so it's tough to generalize. But I think if you're limited in your activities and the medications that you're taking aren't effective, then it's always reasonable to consider levodopa. And really, in all stages of Parkinson's disease, levodopa can be considered an appropriate therapy.
Okay. How might a caregiver or an individual or a person with Parkinson's, and it might be different because one has the ability to kind of feel it and the other one doesn't, recognize these off periods?
So It can be tricky because again, it can show up pretty different in different people. But I think one of the clues, though not always, is how people are doing in the morning. So usually when you first wake up in the morning, that's your longest stretch without medication. So a lot of times off symptoms are going to be more prominent there. There are always exceptions to that. And I do have a lot of patients who say they feel at their best first thing in the morning. So a lot of potential explanations why. But again, you can use that as a clue. If you notice shaking in the morning, that might be more of one of your off symptoms. If you feel stiff in the morning and that gets better 30 minutes or an hour after you take your dose of levodopa, then again, it might be more of an off symptom. So that brings up that second sort of clue is, does it get better when you take your medication? So if you sort of look 30 minutes, an hour, 2 hours after you take a dose, do those symptoms get better? 3, 4, 5 hours after you've taken your dose, do they come back? That up and down period is usually a good clue that it could be an off symptom.
Okay, and final question, does the body use more dopamine during rigorous exercise? And if so, does the timing of that exercise to dyskinesia help reduce peaking of levels?
Okay, so I might need the second part repeated in a second, but for the first part, yes, you do use more levodopa or dopamine when you're more active, but your body also produces more dopamine when you're active. So when you're exercising, you're increasing that blood flow to the brain, and your brain is producing more of its own dopamine there. So yes, you burn through more, but you also might notice that your symptoms are doing a bit better because your brain is producing more. Could you repeat that second half of the question?
Yes, it's if so, does timing of exercise to dyskinesia help to reduce peaking of levels?
Oh, so I guess this is asking if you can use exercise as a treatment to avoid dyskinesia, if I'm understanding correctly, and I haven't come across that. I honestly couldn't say. I don't think it would work that way, but I haven't come across that, if that's what the question is asking.
Okay, that's how I was interpreting the question as well. So I can't give you an alternative to that, but all right. So we're wrapping up the questions because we do have to jump into our very next session, but I want to thank Dr. Tarakad for joining us this afternoon and for sharing all of this information. I think that these are the burning questions people have, and dyskinesia is way up there on the thing that's of most concern for people. So next up, we have our very last session of the day with Maggie Abbott. So please join our Building Your Rehab team. I'm going to jump over to that session and we will get that one started. Thank you, Dr. Tarakad.
Thank you.
All right, bye-bye.